Welcome to the Cardiothoracic Nursing Workshop. First of all, I would like to inform you that the moderator of this nursing workshop is Miss Asma Saif, the head nurse of the Cardiothoracic Unit in Hamad General Hospital. Then I would like to introduce our guest for the presentation, Dr. Rashid Mazhar, consultant CT surgeon. He will be giving a presentation for around 30 minutes. Please, all of you are required to keep your mobile phone silent, or you can keep them on vibration just to avoid disturbance during the lecture. And after Dr. Rashid will finish his presentation, then I'm going to give you some instructions regarding the workshop. Thank you very much.
Thank you very much, Safia. Good afternoon, everybody. And after I finish my presentation, you are free to ask any questions. As you can see, we will be talking about the chest drainage, some principles and some errors. And these are the errors for those of you who are not from Hamad. A year ago, now it is more than 1.5 years ago, we had 3 serious complications for not observing some of those principles, which I'm going to highlight. We have had an internal campaign inside the hospital whereby we avoided any such complication or repeat of the complication last year. So I will start with some very basic concepts about the chest cavity. All of you have seen a ventilated patient, artificially, mechanically ventilated patient, isn't it? And that is almost like if you take a syringe filled with air and you let the air out. That's how the ventilator works. It pumps air into the patient with a mechanical piston drive. That's correct? Normally, human beings breathe in an entirely different way. It's totally opposite of that, what a ventilator does. So what our normal physiological breathing is not by something is pushing the air inside, it's by a very gentle creation of negative pressure inside the thoracic cavity, which facilitates and pulls the air inside. Normally, inside your chest cavity, the pressure, as you can see here, is negative. Negative in respect to what? Ask any 10-year-old who has got 10-year-old children. They must have been taught in the school that the atmospheric pressure is 760 millimeters of mercury. If you take the atmospheric pressure to which all of us are exposed, and we open our mouth, then we are exposed to the atmospheric pressure. So from the air, through the airways, down to the alveoli, if we do not breathe and just keep the whole thing open, it is the same pressure. So compared to the pressure all around us, it will be 0 inside. There will be no gradient, no difference between the two. If I do not make myself clear, please shout. Now, if you keep your mouth closed and you keep breathing normally, then the pressure inside your chest cavity is always less than 0, less than all around us, less than the atmospheric pressure. And it's just that it becomes more negative when we pull our diaphragm down, that is, we inhale. Then the pressure becomes 8 centimeters below 0 on the water scale. Okay? So, and when you breathe out, then it becomes less negative, that is, it moves more towards the. So if you have the 0 here, it goes below 0, 8 centimeters, and then it comes back to 4. Never touches 0. That means it never touches equal to the atmospheric air. That's why your chest cavity is like a continuous barrel, a barrel which is continuously on suction. It always has a negative pressure as compared to the atmosphere. Please remember that fact. That's why if you break the wall of this barrel, air outside is at a higher pressure than inside, so it will enter inside, and it's not the other way around. Okay? This is what I just explained with my hand gestures, and this is the difference between the two pressures. The pressure outside into the atmosphere and the inside of the chest cavity, which is always negative, that keeps the lung always in contact with the inside of the chest wall. Our lungs are always inside in contact with the chest wall, whether you are breathing in or breathing out. It doesn't happen that way, that it falls away from the chest wall during any phase of respiration. So, bottom line, your chest cavity always has a negative pressure. And this is what it tells you, that if that wall is broken, then the air will come inside, or by a disease process, a fluid comes inside, then that system is destroyed in a second. It's a very delicate system. It's -4 to -8. And if there is a break in the wall by trauma or by a tube or by whatever method, or some fluid comes out from the lungs like in pneumonia and effusion, that negativity disappears. And that's why the lung collapses. Now, you can have air collecting inside the cavity. You can have fluid collecting, which could be either blood or could be an infected material. These are the basically three broad kinds of things which collect inside the cavity. The lung inside is not any more different than the softest foam you can buy in the market. So this whole thing is expanded. As soon as pressure becomes positive in the pleural space, it just gets compressed. And the whole lung of a grown-up adult male can become the size of your fist. And the rest is just cavity. It is so soft and spongy an organ. Now, we all know about pneumothorax. When you say pneumothorax, that means collection of air inside the pleural cavity. When we say pneumothorax, by default, we mean closed pneumothorax. That's why I put it in parentheses. Now, this is the pneumothorax, which is produced because of the air leaking from the lung inside the pleural cavity. That contrasting to an open pneumothorax, whereby the air is coming from outside into the, if you look it back, the air is produced by the inside and it's collecting inside. Here, the air is coming from outside and it's collecting inside. And next to these are some devices. This is the Asherman seal, and these are other commercial devices for that. Another, before we go on to the treatment part of it, which is very commonly excite people and it's very commonly taught, but I see that that is not fully understood, that tension pneumothorax. Now, tension pneumothorax invariably comes when you have got air leak coming into the pleural space, and with each breath, air is coming and the same amount cannot get out anywhere. So it is collecting and building and building. Now, there's a very limited space. What will happen if it builds? It will produce pressure, rising pressure in there. Rising pressure on the lung, you have seen in the previous slide. Now I'll go back 2 slides. Sorry. You have seen here, the lung is completely shut down. Okay, but this is not tension pneumothorax. Here, the pressure has gone so much that the space has been like a pushing mechanical mechanism whereby this collection of air is pushing onto the heart. So when we talk about tension pneumothorax, it is a pneumothorax plus tension on the heart. Please remember that. Tension is not on the lungs. Tension is on the heart. And in the heart, as all of you know, you have got the right system of the heart and the left system of the heart. The right side of the heart works on very low pressure, 30, 35, 40 maximum, right ventricular pressure, isn't it? The left side is the main pumping station, which is thicker, stronger, and pumps at 120 or plus. So when somebody pushes the heart and distorts the heart, either from this side or from that side, the veins which are bringing blood into the heart and the pressure in these veins are very close to zero. They are not high pressure pipes. A little push will kink them. You got it? So if these veins are kinked, which you can see in the diagram, then not much will come inside the heart. If it does not fill up, it cannot pump out. Simple. So the tension pneumothorax is a pneumothorax plus circulatory collapse, hemodynamic compromise, hypotension, whatever you call, signs of circulatory shock. Put these things together, then it becomes a tension pneumothorax. Not alone pneumothorax which is large, which is big, which you can see on the x-rays, no. If the person is hemodynamically stable, then he is not in tension pneumothorax. So a combination of pneumothorax plus tension on the circulatory system calls, and that's why we call it inflow occlusion. The blood flowing into the heart, inflow, is obstructed. Now, so far we talked about that the thoracic pressure is negative. The other important point to remember is the closed and open pneumothorax and the tension pneumothorax. That is pneumothorax plus circulatory collapse. Let's talk about drainage. Now, we start from the last one. In the terminology or language of medicine and surgery, this is said an X-ray which should never have been taken, because the diagnosis of tension pneumothorax should be clinical. Once you have seen a person gasping for air and has got clinical signs of pneumothorax and his blood pressure is going down, you presume that's tension pneumothorax. And you see the amount, all the black is the amount of air which is pushing the white in the middle, which is the heart, onto this side. So you can imagine not much is coming inside the heart. That's why that heart is incapable of pumping things out. And this is the famous second intercostal space decompression. Now, if you have a situation like this, just getting out away a little bit from the chest tube, when not much blood is coming into the heart, if you're doing CPR, your CPR relies on that if there is blood in the heart, you will pump it with your hand. But if not much blood is coming inside the heart, your CPR will be ineffective. So you can realize how important it is to diagnose this condition and get rid of that so that blood can start flowing in the heart, so that even if you have to do CPR, that will be effective. If that situation continues, then the heart muscle will lock in itself actin and myosin, and the heart chamber will simply obliterate. The heart will become a solid piece of muscle, which is called a stone heart, hypoxic arrest. Insertion of chest tube is called thoracostomy. That's the professional terminology for it, not thoracotomy. Thoracotomy is opening the chest. Thoracostomy is making a ostium, a hole in the chest. So chest tube insertion, and as you can see, this is called the triangle of safety, the blue thing, the magenta color here. And that is because not much of the muscle is there. That's the pectoralis major here. That's your latissimus dorsi behind. The only muscle here is the serratus anterior and the intercostal muscles. So you've got least amount of muscle to go through, as compared to if you try and put a tube right from here, you will have a thick muscle to pass through. This is called the triangle of safety. All of you are taught that if you are doing, the doctors at least are taught, but very few of them practice that when you are putting in a chest tube, you should not put a blind forceful maneuver, not on this skewer and the tube on it, and you go in and it should be done in an open method, and I'll show you in a few slides later down. In between the intercostal space is as good a place as any. Above, you have got intercostal vessels in any intercostal space, and below, at least on the front, you have got the collateral branches of these intercostal vessels. So the middle one is the right space. Second intercostal space in the previous slide, which I had shown you, sorry, going backward. Okay, this one. Now that's another piece of information. Every nurse, every physician must know how to come to the second rib, how to count the second rib, and how to come down to second intercostal space. You go from the supraesternal notch, you slide your finger down, and you will hit a little road bump. That's called the angle of Louis. It's just like a road bump. And that angle of Louis, get one of your skinniest male friends, ask him to strip his shirt, and then do that, and you will find that's the second rib. Below that, and then you can come laterally and you can count from the second rib downwards. So second intercostal space is below the second rib, of course. Now, how to do that? Naturally, nurses usually do not put in chest tubes, but you must know, because you manage